So hi everyone, my name is Emilie McKinnon and I'll be talking to you today about using advanced diffusion MRI methods to study white matter integrity in aphasia. I have nothing to disclose, but I do have a couple of funding sources, especially that I'm a part of a T32 training grant from the NIDCD. Okay, so why are we here today? I can say with a lot of confidence that everybody here would like to help patients with aphasia, and that's kind of our common goal. But let's talk about that in a little bit more detail. So I'm interested in trying to figure out how we can help patients with chronic post-stroke aphasia. For these patients, we know that speech therapy is their only means for improvement and seeing that their spontaneous recovery has already occurred. And unfortunately, there's still a large variability in recovery from speech therapy, and we don't really understand who has the potential to recover and who does not. So we wanted to ask this very simple question, and wanted to see if treatment results in structural brain changes that we can measure. It's maybe an easy question, but kind of has a difficult answer. So I kind of want to start with having dessert before eating dinner and want to show you some results that we recently published where you can see this is a patient's brain where the stroke is shown in pink. Let me see if I can use this mouse. So this is the lesion. This is the inferior longitudinal fasciculus, a segment of it. Let me show this here on the top. And the tract is color-coded with some sort of measure of microstructural complexity. And we looked at if this microstructural complexity changed before and after treatment. And so you can see here, especially in this location where the integrity was most lost, or where the tract was broken the most, we saw some significant changes from before treatment to after treatment. And this is an example of one patient, but we actually showed that the more recovery happened, the more recovery they showed, there was more increase in microstructural complexity. So I hope these results kind of got everyone's attention, and then we'll be going in our talk, I'll be going through the methods that we used to do the study and how we managed to get such exciting results. So I'll start off with a brief motivation of why we focus on white matter and on microstructure, how we use diffusion-weighted imaging, and specifically how we use diffusional kurtosis imaging, and how we apply this to aphasia. So I'll go in a little bit more, or actually a lot more detail about this work that I just showed. And I'll show some exciting new results in the end where I talk about the use of biophysical models. Okay, so why study white matter? It's probably already known for a long time, but I mean, historically, many people have focused on looking at the cortex, but I want to just show two simple cases where that highlights the importance of white matter when trying to study stroke recovery or aphasia recovery, or just predicting impairments. So here's an example of a paper that was published by Dr. Friedrichsen in 2007, where we had a participant with severe Broca's aphasia. And, you know, if you would ask anybody to predict what their scan would look like, you would probably think that there would be damage to the inferior frontal gyrus, which here in this case that's shown in this red box, which is not the case. The gray matter is largely intact, but you can see this very large lesion running all through the white matter, which is largely messing up the connection to Broca's area and might be resulting in the same symptoms. So clearly here we can see on T1 that the white matter is damaged, so that might be relatively easy to include in your predictions, just overlap with white matter. But what we also want to do, and this was shown very nicely by Dr. Bonilla in 2015, that we want to maybe map the extent of white matter loss outside of the lesion. So in this figure on the bottom, this is a different patient. Mind you, the lesion shown in black, which includes both gray and white matter, but what we show in orange are those white matter tracts that showed at least 90% loss of fibers. So you can tell that the damage that's done to the left hemisphere extends way beyond what we think it is when you just draw a lesion on T1 or on T2. So, and actually what I would like to do is take this even one step further. So many studies have been done now, and you've heard Dr. Bonilla talk here several times already about using connectivity to kind of include white matter into the picture, but I guess that my question is, can we really compress fiber tracking into just one single number of connectivity? Can we just, for example, this bundle here is the superior longitudinal fasciculus, can we just describe what this connection would be by just giving it one number of the number of fibers? And so clearly the way I'm asking this question, the answer would be no. And so this is a study that was done in Stanford where they, for one of the first times, try to correlate different parts of the tract, the microstructure of the tract, with, in this case, it was a reading skill. So if you do that, you can see how the correlation coefficient changes over the length of the tract, and there's clearly an area right over here that seems to have much more to do with reading than any of these other regions. And this might have to do with different types of fiber bundles entering or leaving. Maybe the microstructure is not universe along the entire length of the tract, or maybe just the way we measure bundles is not necessarily one bundle. So we wanted to use this same tool and study the integrity of the tracts in aphasia. So how do we do this? This is mostly done with a technique called diffusion-weighted imaging. Many people are already familiar with the technique. If many of you are clinicians, it's often used in the clinic to identify acute ischemia, and you have images that kind of look like this, a diffusion-weighted image or an ADC map, where in acute ischemia you clearly see a large drop in diffusivity. So, so the advantage of diffusion MRI comes from the technique being sensitive to the type of water diffusion, and it's sensitive to the tissue microstructure. And before we go into a little bit more technical details, I kind of want to maybe give you a better feel for what that sentence means, so you can kind of conceptualize what diffusion MRI is measuring. So imagine you want to build a model of a city without ever going there. So this is a picture of, I believe it's New York, and imagine you want to know where the buildings are, where the streets is, or how big the streets are, but you don't want to go there and map it all out yourself. So cities are populated by lots of people, especially big cities like this, and we have people walking around everywhere, kind of probing the city for you. You can't walk against a building or over a building, or if streets are wider or smaller, the flow of people will be different. And so in modern days now, we all have a cell phone in our pocket that's continuously sending out signals, what we can measure, and we can kind of follow these signals to kind of see how fast people are going or where people are. So what you can do with that, there's some people that can do some calculations using some fancy or not so fancy computers, and you can build a model of the city just like you were seeking out to do. Of course, we're not interested in building a model of cities, but if we take this analogy to the brain, imagine I want to know what the brain looks like without ever setting foot in it, right, or doing histology. So we don't have little people walking around in our brain, but what we do have is water molecules that are probing the environment for us constantly. And what we can do with an MRI machine is we can make them send out signals about how, like where they are and how fast they're going, and so we can send ourselves into the MRI scanner. use some fancy computers and actually get some sort of idea what the microstructure looks like without ever doing histology. And that's exactly what diffusion MRI provides us. So let's go back to diffusion-weighted imaging. Maybe the sentence makes a little bit more sense now. So the advantage of diffusion MRI is that water diffusion makes us sensitive to tissue microstructure. So there's two broad categories of applications of diffusion MRI, or more or less, one of which is tractography and connectivity. You can see a beautiful example here on the slide of tractography and showing us kind of the connections on our brain. And I won't be talking much about connectivity today, but that's, you know, very, very common. But the other thing that you can do with diffusion MRI is measure microstructure. And many of you probably have heard of these next couple of terms. Let's see. So simple measure of microstructure would be mean diffusivity, something we could calculate using diffusion MRI, kind of showing you some sort of a measurement of the average speed of the molecules in each voxel. Or fractional anisotropy, also very common, tells us something about the directionality or the preference of a certain direction over others using of water diffusion. So if inside of an axon, FA will be very high because all water molecules would be kind of moving the same way instead of kind of them spreading out. But then I want to introduce to you some other measurements of microstructure this talk, one of which is called mean kurtosis, something that we can calculate that will kind of give us a measurement of complexity of the tissue. And another measurement that we'll introduce to you at the end is called axonal water fraction, which gives us an idea of the amount of water that's particularly inside of the axons, so which could tell us something about, for example, axon density. So kurtosis, what does this mean? In my research, I use this technique called diffusional kurtosis imaging, and I'll try and explain this to you what this means. There'll be a little bit of math for the next couple of slides, but hopefully not too much. So not all diffusion is the same. What does that mean? And actually, luckily for us, it's not all the same because the changes in diffusion pattern is what actually gives us all of the crucial information that we're looking for. So here on this little video, you see an example of water just diffusing freely without barriers. So this is something we call free diffusion or Gaussian diffusion. And if you would make a little map of the distance these molecules travel versus the amount of molecules that travel that exact distance, you would get a nice bell curve or a normal distribution. And this is kind of the underlying foundation of diffusion tensor imaging, which is one of the most widely used techniques in the field. But I don't think it's not really realistic to assume that water diffuses freely in our brain. There's many barriers, there's many different types of cells and structures that are preventing water from diffusing freely. So maybe diffusion looks a little bit more like this, where the molecules don't have a chance of, in this case, going to the left or to the right, and they're kind of forced in different directions. And so what this does to this type of curve that we plotted on the left is it actually introduces some sort of tailedness or some sort of deviation from a normal distribution. And this is exactly what kurtosis measures. This is a measure that has been like invented in the past by statisticians on how to quantify something as not normal or deviating from not normal. So it's called kurtosis, and it basically measures your tailedness. But the interesting thing for us is that this deviation from normal is driven by the membranes or the compartments in our microstructure. So basically, this is kind of a surrogate measure for telling us how complex the environment is. And I want to give you first a very simple example of how powerful kurtosis could be. So this is one of the very first experiments that was done by Dr. Jensen in 2005. Imagine you have 6 vials with different sort of water with sugar in it, so sugar water. It has different concentrations. And one of them, we added some pureed asparagus, so something that's very finely mushed up, so it doesn't have chunks or anything. And we want to be able to see if we can predict which of the vials has this asparagus in it. So if we put this set of vials into the MRI scanner and do diffusion MRI, this is what the mean diffusivity would look like. It seems very homogeneous. You might think this one on the bottom right potentially is the one with asparagus, but there's not a clear distinction. The diffusivity seems to be very similar depending on if there's asparagus or sugar molecules in the water. If you calculate fractional anisotropy, there's even less difference. There's no preference for directionality in any of these vials. But if you calculate the kurtosis of all of the vials, you can clearly tell that the vial that had asparagus that was introducing barriers was this one on the middle right over there. So maybe this measurement of kurtosis could tell us something about tissue microstructure in vivo using MRI. So before we go into some more details, or actually in applications, not too many more details, another thing that kurtosis can do is improve upon our tractography. So this is an ellipsoid kind of showing the preference of directionality within one voxel. So basically, along the long axis of the ellipse is what water is preferring to diffuse in that direction, and not as much so in the short axis of the ellipse. And so this is something we call a diffusion orientation distribution function, or an ODF. And in this case, because it's an ellipsoid, we kind of we calculate this using this Gaussian assumption that I introduced in the beginning. And so if we want to do tractography, so this is an example of DTI tractography, where, let me see if the mouse can come back. So this box is kind of this area zoomed in. If we want to do tractography, we would kind of put a seed point somewhere and follow these maximums over the long axis of these ellipsoids. But this area is very complicated for tractography because it's an area where 3 regions cross. You see the corpus callosum is coming, oops, and there's my mouse. You can see the corpus callosum is coming from the bottom left and kind of crossing through here. Then there's the cortical spinal tract that's coming up, and then the green is the superior longitudinal fasciculus, kind of like coming outside of the plane. And using only an ellipsoid to represent this, there's no way that you can clearly distinguish between these directions. So, but what DKI can do, so this is what a kurtosis diffusion orientation distribution looks like. It looks like this is more of a clover shaped or a much more complex shape that we can calculate using kurtosis. And if you then do tractography, it clearly picks out all the different bundles. So you can see the corpus callosum is able to just go through this area of crossing fibers, which here it was like this mix of purple, and here the blue is able to go all the way to the top, and then the green bundles are all the way able to come out of the front as well. So we can improve upon tractography using kurtosis calculations as well. So I'll show you a little video of just the whole brain to kind of bring home this point. So on the left, there's an example of some sort of, this is DSI for the people that are familiar with it, but let's just call it a golden standard for now. In the middle is DKI tractography, and on the right, you'll see what the brain looks like using DTI tractography. Okay, let's see if this works. Yes. So, so here on the right, you can kind of see how the corpus callosum is a lot more, or not as full, caused by the fiber crossings. And that the DKI is a little bit more similar than to the golden standard. And here, this is the same area of crossing, a lot of crossings, where DTI kind of just picks one route out, while in DKI or using DSI, you can kind of follow it all different directions. Okay, great. So now let's go to some applications, which would be the most interesting part. So, okay, so let's start with an hypothesis, and this is what we were trying to find out, kind of what we introduced in the beginning. But more specifically, we wanted to see if therapy-mediated semantic recovery was associated with strengthening of the residual inferior longitudinal fasciculus. So we were trying to see if strengthening was something we were going to measure using kurtosis, like introduced before. The residual inferior longitudinal fasciculus was going to be located using kurtosis-based tractography. And then we were focusing on semantic recovery, and I haven't talked about that yet, but I will introduce to you in the next slide why we were particularly interested in semantic recovery. So the dual stream model of language, this is something that most of you probably know a lot better than me, but basically the dual stream model of language suggests that when we speak or during speech production, there's two different subsystems at play, one of which helps us to map the meaning onto words or semantics, and this is done by the ventral stream. So imagine you ask a subject with aphasia to say the word table, which would obviously be the correct word, but if there's some conceptual problem, then maybe the answer would have been chair, which would have been an issue in semantics. Or, and then the other subsystem is more where we map the meaning onto spoken sound structure, how we're really going to say this word that has been chosen in this kind of first step. And this has been is regulated by the dorsal stream. And an example, if this would go wrong, could be, for example, the word cable comes out instead of the word table. But in this project, we were interested in semantics, like I said before, so we were focusing solely on the white matter of the ventral stream, which in this project, we were looking at the inferior longitudinal fasciculus specifically. Okay, so some backgrounds about the subject that we had. So this was some pilot data, and we had 8 participants with chronic post-stroke aphasia, 3 females, 5 males, mean age of 52 years old, and everybody had their stroke at least 1 year prior to acquisition of the images. Every subject underwent 60 hours of constraint-induced language action therapy. It was, I think it was 20 hours a week, 4 sessions of, or 5 sessions of 4 hours. And everybody got the Philadelphia naming test before treatment and after treatment, and I got MRI data before and after treatment. Important is they got 2 MRI data sets before treatment and 2 MRI data sets after treatment that kind of allowed us to study variability just with time instead of variability with treatment. Okay, so this is a broad overview of our image processing pipeline. Here on the left, you see just the raw diffusion-weighted images that are acquired. To be able to calculate kurtosis, you need to add another b-value to your acquisition. So it's more standard to add to calculate just a b0 and a b1000. But so you have to add a b2000. And with modern scanners, you can do that in maybe 4 or 5 minutes. So it's still very clinically feasible. So Next, we calculated mean kurtosis. So this is an example of a mean kurtosis map where you can see that the complexity of the tissue is severely reduced already in this white matter here surrounding the lesion. You can calculate the kurtosis tensor using some software that's online available for everybody called DKE. And here's the link on the bottom. And then after that, we did this, we tried to find the inferior longitudinal fasciculus using this technique called AFQ, or automated fiber quantification. So basically, you locate all the tracts of the brain and then kind of filter out which tracts you think are part of the inferior longitudinal fasciculus, which you can kind of see here. And then they kind of get chopped off at two well-defined places, which makes calculations a little easier. And then we kind of compress this whole bundle into one average bundle, which you can see here on the right, and it's color-coded also with our kurtosis measurements. So, let me go back. So this is kind of what we started off with. So for every patient, we had one centroid that was color-coded with the kurtosis measurement, so we can kind of study how the complexity changes along the path, and this is kind of what that would look like on the right. And some of this is natural fluctuations on healthy brains. You can see some fluctuations in complexity as well, but for some of the stroke patients, there's definitely some microstructural changes there because of disease. So this is kind of a bird's eye view of what the different microstructure looks like in this subset of patients. So let me orient you. So we have on the x-axis, this is kind of along the tract values of FA, mean diffusivity, and mean kurtosis. So starting at the anterior side over here, going to the posterior side over here. In red, you can see the contralesional side, and in blue, the ipsilesional side. The solid line is the average microstructure along the tract of all of the patients, so average over all 8 patients, and the width of these little lines is the standard deviation. So in general, the FA is lower, the kurtosis is lower, and the mean diffusivity is higher for the patients, comparing the ipsilesional side with the contralesional side. And another thing that's striking is, so the contralesional side, which technically would be the healthier side, has a lot less variation in it. So maybe this variation could tell us something about the individual's performance, and that's kind of what we were trying to find out. So here's an example of what these individual variations look like within one tract and within one subject. So here is an example of the inferior longitudinal fasciculus colored with mean kurtosis, and the lesion is kind of shown in like bubblegum pink. And so you can see that the complexity of the tract seems to be a lot higher when you go further away from the lesion, and the closer you get to the lesion, there seems to be some sort of maybe some sort of loss that's making this microstructural environment a little bit less complex. And so when we were trying to figure out how this changes with treatment and what if this is supporting semantic recovery, one of the questions we asked ourselves was, which part of the tract should we look at? Like, which part of the tract do you think is going to change first? So if you think about a network only works as well as its, I guess, weakest segment. So we tried, where we quantified something that we coined the tract bottleneck, thinking that the spot on the tract with the weakest microstructural integrity might be the location that needs to heal or change first. So this is a kind of an illustration of that, where like signals are being sent out along the axons, and then there's some sort of problem here, and then the signal kind of, you know, doesn't go through as well. Obviously, this is just a cartoon of what this might look like. But so the way we assess this weakest segment was by looking at diffusion abnormalities. So we defined it by the minimum in kurtosis, or the minimum in FA, or the maximum in mean diffusivity. And then we looked at if this was the location where recovery happens. So this is trying to get back to that figure that we started off with. So we were looking at the changes in mean kurtosis. So basically, this will be the x-axis, where larger changes in mean kurtosis, positive changes, will be more complex after treatment than before treatment. And here the change in semantic paraphasias, which is the y-axis, the more negative the number will be, the better, because it's the amount of mistakes they're making. So if they made 5 mistakes after treatment and 3 mistakes before treatment, and, you know, you get 3 minus 5, which would be a negative number. So if we plotted this out for all of our subjects, we got this beautiful correlation showing that the patients at the bottleneck of the inferior longitudinal fasciculus had a higher change in kurtosis, were those patients or those subjects that showed a bigger change in the amount of semantic paraphasias. And so here's this same figure again that I showed in the beginning, and I'll go through it one more time. This is the inferior longitudinal fasciculus. Now we know that this area is the diffusion bottleneck, and the color is mean kurtosis. So this patient showed a 55% change in semantic paraphasias and had about a 10% change in mean kurtosis. So some other results. So this top part was the change of mean kurtosis at the bottleneck with the change in semantic paraphasias. Which had a correlation coefficient of 0.9, and we also related this with amount of phonemic paraphasias, so kind of confirmed that maybe this part of the brain is not responsible for the phonemic aspect of language, and saw that there was no relationship there. And the other thing that's interesting, and we're working out this idea a little bit further, is that the mean kurtosis before treatment was also just related to the absolute value of semantic paraphasias, not necessarily the change, just the amount of mistakes that were being made, with a correlation coefficient of 0.82. Then most interestingly is that mean kurtosis was the only metric to reach statistical significance in all these subjects. So we didn't see the same relationship with FA, we didn't see the same relationship with mean diffusivity. So maybe kurtosis is telling us something different about the tract that we weren't really able to quantify before. So just to recap this study, so we saw that the changes in microstructure of the inferior longitudinal fasciculus was related to semantic, but not the phonemic performance during naming in patients with chronic aphasia. Maybe mean kurtosis is more sensitive to structural changes related with recovery. This could be twofold. So either we're measuring something different, but just the other thing I would like to mention there is that mean kurtosis is a parameter that is less affected by partial voluming than either mean diffusivity or FA, so it might just be less noisy. And then the last thing, what everybody was probably wondering is, what does this mean, changes in mean kurtosis? Like, what is changing in this bottleneck? Is there new axons growing? Is the diameter changing? There axonal sprouting? Is there myelination, remyelination? So that's very hard to tell from these measurements. It's very hard to say if it's one thing over the other. So the remainder of the talk, what I would like to introduce you to is something called biophysical models that we will use to try and interpret these results. I do want to stress that once you start using biophysical models, you have to start with assumptions of what neurons might look like, or how this environment, how you can describe this environment with some more simplified mathematics. So everything that I've talked to so far is basically just physical measurements. There's very little assumptions there, but going forward, we're making this assumption, and I'll show you here. In the model that we were using, we're making the assumption that neurons are actually, that they're made up of thin cylinders, or you can approximate them as thin cylinders that are impermeable because of the myelin. So here's an electron micrograph of bundles of axons. So, you know, they kind of look like cylinders. So maybe that's not that far-fetched, but I just want to make sure that that's clear. That's the assumption that we're making. And we're also assuming that there's no exchange. So we have, so this is a kind of cartoon drawing. So there's water inside of the axon that's shown in red. There's water outside of the axons that's shown in blue. And there's no exchange between these compartments. And so measuring these specific diffusion metrics could potentially tell us a little bit more about what's going on. For example, if we can see that the blue diffusivity is going up, but the red diffusivity is staying the same, maybe myelin's changing, because that would make sense with this figure. Or maybe if red is changing and not blue, maybe there's something going on at the axon diameter or something like that. So splitting up the diffusion signal in these different compartments gives us a little bit of a better idea of what might be going on. So, and I'm going to show you some sort of an animation to try and explain this better, how this works. So this is our assumption of how neurons might look like in our brain. It's very cartoony. So we have water inside of the axons, which we coin intracellular diffusion. Water outside of the axon, which is called extracellular diffusion. And an exchange component that we will ignore. So I say we, like this model was developed in our lab by Elsephiremans a while ago, and so this is the model that we're using. It's called the white matter tract integrity model, just to be clear. And this is what it might look like in stroke. So before stroke, we have water inside the axons, water outside the axons, but maybe if there's ischemia somewhere, maybe some axons die. So here we have 2 axons less than what we had before. And so you can clearly tell that here we had 4 red lines, and here we have only 2 red lines, that there is less water inside of the axon than there's outside of the axon that there was before. So something we've been measuring is something we call the axonal water fraction, which basically tells you the ratio of the amount of water that's inside versus the total amount of water that's in your voxel. So if the axonal water fraction goes down, either it's likely this is being driven by less signal coming from inside of the axons. And that's something that I've been investigating now, because this can also be related to changes in kurtosis, to understand this better. So I'll show you some exciting preliminary results using axonal water fraction to try and understand these changes in stroke a little bit better. One thing I'd have to say, these data is only baseline data so far. I don't have any after treatment data just yet, so it's a little different than the previous paper we talked about, but exciting nonetheless. And as soon as we have some post-treatment data, I will do very similar experiments. So in this case, we had 24 subjects with post-stroke chronic aphasia. 57 years old, 75% male, and we looked at the axonal water fraction first, just the whole left hemisphere versus the whole right hemisphere. This is this first line. Saw that the axonal water fraction is significantly different in the whole hemisphere. So maybe pointing towards some widespread axonal loss. Then we saw that so same for the left temporal lobe, had significantly lower axonal water fraction or maybe axon density compared to the right temporal lobe, and Oh, yeah, sorry. Yes, yes, this is excluding the lesion. Yes, so the left parietal lobe and the right parietal lobe, and then, but then another very interesting point is that a decrease in axonal water fraction, just percent-wise, was in the left compared to the right temporal lobe was associated with an increase in semantic paraphasias and not in phonemic paraphasias. So the lower the axonal water fraction was in the subject, the more semantic paraphasias they were making. So maybe pointing towards some more axonal loss. So that was an ROI-based analysis, and so then I looked at this along the tract, very similar to what we've done before in the previous experiment, and showed that axonal water fraction is also very relatable to the percent semantic paraphasias, and this was specifically in this location is shown in yellow. But this is all very preliminary, and this is kind of what I'm working on right now. But so the idea is that maybe axonal water fraction could tell us a little bit more why kurtosis is changing or any of these other modeling parameters. So to conclude, we used two novel techniques to perform this work. We were using diffusional kurtosis imaging, both for measure of microstructure and for improving upon tractography. And then two is that we measured the microstructure along the tract instead of just averaging out numbers or just saying the amount of fibers that were present. We showed possible evidence of therapy-related neuroplasticity in the inferior longitudinal fasciculus. And we're working on trying to interpret these kurtosis changes, I guess, non-invasively using biophysical models. So the last two things I wanted to say is why we're doing this. One, it's great work for understanding the neurobiological mechanisms of how language might work in the brain. But then second of all, we would like to use these techniques to in the future potentially have a clinical impact of predicting recovery if we can quantify remaining microstructure, remaining integrity, and potentially guide treatment strategies, for example, phonological versus semantic types treatments. So of course I don't do this work alone. I would like to thank my mentor, Leonardo Bonilla, and my other mentor, Jens Jensen, who helps me with the diffusion work, and everybody else at MUSC and USC. And I'd like to conclude, and if anybody has any questions. Gregory?
So that relationship with behavioral measures that you see in a cave, do you only see it in the bottleneck, or do you see it in some other points along the tract?
So with recovery, the only location where, sorry, yeah, thank you. Sorry, let me repeat the question first. The question was if we only saw the relation to these changes related with recovery at the bottleneck. So for recovery, yes. But I just want to reiterate that we have a very small sample size. That's for recovery. That's where we saw the changes. But for just like the baseline impairment seems to be driven by maybe kind of like the integrity of the whole tract and not necessarily the bottleneck. Bree?
When you were talking about drawing the ILF using AFQ, you said you had 2 baseline scans and 2 post scans.
Oh, yes, correct.
How similar, especially when you have a lesion in that location, how similar can you draw the ILF both times, like at baseline and post? Because I know it's quite difficult to track.
Yeah, so let me repeat the question. We did have 2 baseline and 2 post-treatment scans. How similar were the tractography? So what we did in this study is actually use the same tractography for all 4 time points because we wanted to focus on changes in microstructure along the tracts, then in changes in tracts themselves that maybe could have been caused by the methodology and not necessarily by the treatment. So what we did is we actually made one big data set to do the tracking in, using every data we had on that person to kind of improve upon the tractography, and then use the microstructural measurements along back to each time point. But so we did show that the changes before, the 2 scanning sessions before, those were not, to kind of see that we didn't have just spurious changes that were related to therapy. So if we did that with the 2 therapy sessions, or the 2, imaging sessions before, we didn't see any of those relationships.
And was it difficult, just follow up, because I know the ILF, you're going to have a lot of lesion, splitting in half. Was it difficult to, map the complete ILF in people who have that?
So the question was if it was difficult to map the ILF. So it's a good question, and in this case, it was not. From all 8 patients, all 8 of them had an ILF, but we did have those problems with the arcuate fasciculus.
Okay, yeah. That's what I said.
Because so that's my next goal, is to try and improve upon this, so I can track the dorsal string better, and then and that's what I'm working on. So we're also working on some newer techniques with even higher p-value scans called fiberball imaging, that actually focuses on water coming from inside of the axon specifically. And so if some of the patients have a very large amount of edema or extracellular fluid, which can mask the tracts using our current techniques, so we've been using higher p-value scans to kind of draw out that signal from inside of axons that might be there, to be able to improve on this tracking. But it's tricky to get these newer techniques on patients, so it's something we've been working on. Yes.
Yeah. So some of the work, particularly with functional connectivity, I would say, starts from the idea that maybe the architecture would still be present, but the function of those connections is limited, right? In your last measure, well, particularly in the last measure that you talked about, the AFW, you seem to suggest that you get changes in these measures in the absence, if some axons are gone, right? So I'm just wondering whether your preliminary results mean that is in fact the case, and in these cases with loss of function that's associated with the axons actually physically being gone, severed, or however, or whether it's possible that the architecture would still be in place, but that something else happens to whatever is inside it that gives you different measures.
That's a good question. Do you want me to repeat it, or is it?
Yeah.
Okay. So the question was if in the preliminary results of the external water fraction really is showing some sort of a decrease in axons, because a functional MRI kind of suggests that maybe the structure is still there, but the function is lost. I hope I kind of wrapped it up, more or less. But so it's really hard. I mean, it's really hard to tell, to really predict what these measurements mean. It is possible that it's giving us a better idea of what's going on, but it's still possible that maybe there's just less water in the axons than there was before, not necessarily no water, or you mean not necessarily there's no axons anymore. That's something that needs to be validated using animal studies, or seeing that it's a fraction. It's possible that the denominator is also increasing, so maybe there's more extracellular, even more extracellular water. So I don't know, but I think it would be interesting to actually relate these results to functional MRI as well, that maybe these changes in functions are not only driven by connections being there, because I think most of that work is being done by connectivity studies, correct? So potentially, maybe the microstructure along these fibers was not as good, but the fibers are still there, and that's kind of what this technique might add, and maybe it would be able to tell us that this might be why the function is not very good.
It might even have implications for recovery, right?
Oh, for sure. That's
the neural mechanisms of recovery. I guess it potentially makes a difference whether the architecture is there.
Exactly.
Likewise, from animal studies, now that you brought it up, do we know anything about the thickness of these columns that you showed on the microscopic view of the cell? Whether their thickness individually is, or as a cluster maybe, is associated with speed of signal processing or something else? Sturdiness.
I don't know. I would. So the question was if the thickness of axons,
Yeah, the diameter, right?
or the diameter of the columns, or the, I guess, is related to processing speed, and I would have to say I don't know. Sorry.
It should be.
We have a question from online. Shall I read it out?
Sure.
So people online can read this, so you don't have to repeat it again.
Okay, good.
From Taylor, who we all know and love. Have you explored a multimodal approach yet to predict? Have you explored a multimodal approach yet to predict patient behavior deficits? For example, does DKI significantly improve behavior deficits compared to just lesion data alone, or just perfusion alone? Could DKI be used as part of a larger way to predict impairments and recovery from stroke, rather than just a method by itself? I think it will be interesting to see its weight in a predictive model using a few other imaging predictors as well. Good talk, by the way.
Great. Well, thank you, Taylor. I think that's a great suggestion, and we are working on that. So the pilot data I showed was had 2 little patients to really make a predictive model, but we are working on doing exactly the things that you just mentioned to see how much extra information this microstructural measurements bring to predict recovery or impairment. Now we already have about 30 subjects, and we're collecting a lot more things to CSTAR, and hopefully I'll be able to answer that question in the next talk.
What do you from the defense?
And we have yet another one from Ekaterina. Why didn't you include other tracts from ventral stream, inferior fronto-occipital fasciculus and uncinate fasciculus, which are also associated with semantic processing, into your analysis?
Great question. So I feel like I'm repeating myself, as in that's kind of what we're working on right now as well, just because the data that we published in the paper had 2 little subjects. We wanted to minimize the multiple comparison problem, and we just decided to focus on the white matter of the temporal lobe. But that's something that we will be doing, and especially I would like to not only not only calculate these things just one stream at a time or one tract at a time, but really make some sort of a connectome combining these measurements with that to kind of see kind of where that leads us in terms of prediction. But thank you.
No other questions from online.
Great.
Thank you very much.
Thank you, everybody.